to welcome you this afternoon. My name is Susan Kish. I'm one of the founders of the Data for Good, and I of this conference and on the program committee. And thank you all so much for joining us. Our first one is from Galen Stocking. Galen is with the Pew Research Center, and he's working on the Journalism Project, and is going to talk about searching through news through the Google Health API. Galen.
All right, thank you for having me. It's really a great honor to be here to talk to everyone about this. So I'm going to talk to you a little bit about what we did for a project in which we looked at how people search for information related to the Flint water crisis. We used the Google Health API, which is a kind of special API and gives a little bit different data than what you may be used to. And so I'm really going to go into what is unique about that data and some of the challenges that we faced when we were trying to work with it and how we overcame some of them. So basically, some broad characteristics when you're thinking about search data is, first off, remember that this is not necessarily representative of the entire population. Search data is representative of people who actually use that interface and that website to search. It does not include people who are not online, people who use different search interfaces or anything like that. The data we were using goes back to 2004, so you can explore changes over time. It has different geographic levels, so you can look at the worldwide level, country level, state level, and in some instances, the DMA level or the city level, broad city level. So we try to answer questions. Using this data, you can answer questions about attention. You can't answer questions about opinion unless you craft your search results very, very precisely. So there are a couple different kinds of data sources you can use from Google. There's the Google website and the Google Trends API, which are basically the same thing, just one is a website, one you can access programmatically. What's different is the Google Health API, which uses much of the same data, but it has a broader sample. And instead of being normalized like the Trends website and API are, where everything is scaled to the highest value that is returned within the data returns you get, the Health API gives you somewhat closer to raw numbers. So quick overview of what we were doing. We were looking at how Google searches can connect with news coverage and what they can really tell us about how people, when confronted with a health crisis, try to find out more information about it, whether it's at that local level of the people who are actually really connected to that health crisis, or nationally when you hear about it on the news and you wonder, is this something that can affect me and my family? So we also wanted to see how they evolved over time. So we used this Google Health API. We also audited local and national newspapers and TV and digital results and Twitter results and put them together to get a timeline and a sense of when events were occurring and how they connected to each other. So here is the interface for it. Here's our final report. If you're interested in more information on it, I encourage you to go to journalism.org and read up on it. It's quite long, so I won't go into it anymore. Our basic design was that we looked at 3 different geographic areas, just the broader US, just the state of Michigan, and the Flint DMA. We looked from 2014, which is about when things began, through middle of 2016. Now, of course, this is a health crisis that's still ongoing, but that was when our time period actually ended. We had 5 different search categories. One on news and media and news coverage of the crisis, one on politics, so who is responsible, where can I find out more information about contact my representative, things like that. Broader public health questions, personal health and how it affects yourself, and then specific contaminants like looking for water and lead together. We looked at a bunch of papers and online sources and TV sources. We used Twitter data. And then when we got all this data together and we started looking at it, we realized that there's some real challenges in working with search data. Doesn't mean you shouldn't do it, but you should really be thinking about these challenges as you're going through it. First off, figuring out what the search terms actually should be is very challenging because you have to think about what people who just heard about something and want to learn more about it might be searching. You need the precise terms that they're using, and you need to think about things that are going to be large enough, that are going to have enough coverage that you'll actually get results. Because if the results are too small, you won't really get any kind of data that you can use. You also have to understand how Google samples and how they provide the different levels of sampling that they do for your data. deal with some weird quirks with zero values, and then figure out how to interpret and present data in a way that people can actually understand it, because you can just throw a bunch of numbers at people, obviously, and they won't necessarily get it. All right, so the first one, when we were trying to develop search terms, we brainstormed a lot. We talked to people, we talked to experts, we looked at language usage within the media outlets that we were studying. We did all sorts of things like that, and developed a list of, the other thing that we used was some of the tools that Google itself provides, such as AdWords, Google Correlate, which tells you which words go with other words, and then autocomplete, in which we had a list of STEM words, about 10 lists of STEM words, so Flint water was one of the STEM words. And then we actually just had people go through and, Flint water A, and then 10 terms would come up, and we'd record all those. Flint water B, 10 terms would come up that start with B, and record all of those. And then from that, we were able to develop the list of 4,000 something or 6,000 something terms. The second challenge is with sampling. The Google API, the Trends API gives you about a 1% sample. The Health API gives you about a 3% sample. What you're actually getting is a sample of a sample, and it's very complicated. I'm not going to go into it here. The nice part about the Health API is whereas this doesn't work. The Trends API is going to be scaled to whatever the highest value is. So if you have on 1 week that this is the highest value within the data set that you're returning is 100, then everything is going to be scaled up to that. With the Health API, it is not that's not actually what they do. They just return the raw value. However, the raw value is not actually a meaningful number in terms of if you just look at it and say 14. That doesn't mean that there were 14 searches. Doesn't mean it was 14% of searches. It's generally a very small number that's scaled and multiplied at some point. And what that means is that you can really look within the data set, but comparing cross data sets becomes more problematic. It's a little bit easier with the Health API, a little less easy with the trends data. And then, so another big problem that results from some of that is the variance that you can get. So we took 50 samples of our news and media category. We scrunched a bunch of terms together that were about news and media, and we plotted them. And you have some areas where you have fairly low variance, and then some areas where you have very high variance. And so it's a really big challenge on what to work with and how we wanted to actually deal with that. And that is a consequence of some of the sampling that they do. Another big challenge that we saw were a bunch of values where there was 0. So if you look all across through here, those are instances in which at least one of the samples, maybe more than one of the samples, returned a 0, and other samples returned not 0. So we had to impute what that actually was. So not all data actually had that. Some of our terms were less sparse. They returned more data. And so we don't see those kinds of problems. So in order to work with it, well, the 0 values occur because of a privacy threshold that Google creates, so you can't actually figure out who's actually searching. So as I said, it occurs when it's especially sparse. So to deal with this, we drew 50 samples, and then we imputed the values of what that should actually be based on the characteristics of that sample itself, and then other data points for that actual week that we were searching for. So when we do that, we end up being able to take the mean of all of the results and get this. Problem then we have is that this is still very difficult to talk about. You can't really talk about all these fluctuations because a lot of them are just noisy. They don't actually mean what you think that they could mean. They may actually have no meaning at all. So we then use a generalized additive model to smooth it out, and then that made what this actually is. So then we took a change point model to try to figure out what actually is a meaningful change. Even with the smoothing, we found that there were a lot of peaks and valleys that we didn't think were actually meaningful. So a change point model determines, it breaks a time series into periods in which there is some kind of meaningful change between them. So we took that, and then we only looked at the change points in which there was a 30% difference between the peaks. And so we were able to get some of these data points out of that. Other issues is we don't actually have real numbers that we can present to the public, so we had to do this larger, smaller proportion, but it kind of shows what's going on. And I'm running short on time, so I'll skip over this. So some of our main findings out of this were that there was a disconnect between what people were searching for in Flint and what the media was talking about. The media didn't catch up to it quite until after the public was already searching for it. We did find that there was always heightened search activity around major events in the crisis, and so that was encouraging that people are actually searching for information when things occur, and that sometimes the news wouldn't be reporting on things when people were searching and vice versa. So that's it. Thank you very much. And I will move on so we have a couple other slides.
Thank you. As I said, unfortunately, we get a little rushed, but I'm really looking forward to our next speaker. Orianna DeMasi is a PhD candidate in computer science at UC Berkeley and is talking about false conclusions that can come from personalized health tracking. Orianna.
Hi, I'm Orianna, and I'm very excited to be here to talk to you today. I'm going to focus on two things. First of all, I'm going to talk about an example of how poor evaluation could lead to the opportunity for false conclusions, and in particular, I'm going to look at this in the case of a medical health tracking. Based on this experience, I'm going to pose 3 suggestions of how we could avoid similar situations in future endeavors. So first of all, to motivate, I would like to talk about mental health is a widespread problem. Depression, the World Health Organization thinks, is a leading cause of disability worldwide. And in the United States, 43 million Americans suffer from any mental illness. So this is a really big problem. But people are thinking, smartphones are ubiquitous and they're personal. Can they be used in novel ways to help mental health care? Is there anything that these devices can provide, whether a new platform to deliver care or a tool that can be used for new treatments or to augment existing treatments? So one thing people are thinking about is that the smartphones know a lot about us. They know about our behaviors, such as our social contacts, our mobility, our activity. And so the thought is maybe we can use predictive algorithms to generate this plot of mood over time. So can we track your well-being over a period of time? And this is what I'm going to focus on, is how do we evaluate these prediction algorithms to see whether they're any good? But just to back up for a quick second, I would like to emphasize that this is actually a very important problem. And if we were able to solve this, we think it would be beneficial for, these are 3 examples. First of all, it would increase understanding of disorders. So hopefully people would be able to be more empowered in tracking and treating their own disorders. It would enable just-in-time interventions. So if your mood plummets, maybe a clinician could call you and check in, make sure everything's going okay, or help provide support. And it would facilitate long-term treatment evaluations. So this would completely change how we could evaluate pharmaceuticals over very long periods of time if we had objective tracking, potentially. So we think this would be good. So this is how it's often studied. We collect 2 types of data. We collect a ground truth by actually asking people, how are you doing? And then we collect passive phone data. So where are you going? Are you active? Stuff like that. So 2 types of data are collected, the phone data and the human input. And the data I'm going to show you was collected in our study at Berkeley. So this is what the data looks like. So the horizontal axis is a measure of time, and the vertical axis is mood or well-being. This is the data I'm showing you for 2 participants, and the dots indicate input that somebody actually input into their phone expressing how they felt on a given day. The line, the dashed line, is the mode over all observations in this example of these 2 participants. And so we can see that sometimes the mode is the same as what the user reports. This indicates where the individual's mode is. So the green and the yellow line indicate for each user what they report most often. So we see 2 important observations. The gray line is not the same as either of the green or the yellow line. And the yellow and the green line are at different points. So these users indicate a different state usually. So they don't have the same behavior, right? And so this is a very simple observation. So this is the population, this is the personal, they're not the same. That's the point. So the population baseline is what if we guess that a model is always we wanted to see if a machine learning algorithm is doing better than a constant model that always predicted all users to be the same. That model we're going to refer to as the population baseline, which assumes all users are always the mode of the entire population. The second baseline we're going to talk about is the personal baseline, where we take the mode over each user's input. And that's the key thing, is each user, and that's going to be more accurate, right? And if we look at the results, if we plot this on individuals, we see the following. On the right is the personal baseline, and each dot here represents one individual in our study. And they have a blue dot to indicate what the personal baseline, how accurate a model that always assumes them to be their most common state would be. And the left, the gray dots, are the population baseline, so how accurate would a model that always assumes everybody to always be the same? And we can see these are different, right? So the population baseline is lower, indicating lower accuracy. This is not surprising given the previous plot. What's important is if you have a machine learning algorithm and you compare it to the population baseline, you might be like, hey, we're doing really great, we beat it. But it doesn't indicate that's necessarily better than the personal baseline. This is really important because both models are clinically useless. Predicting somebody to always be the same state is not useful. So we need to show that models beat both of these baselines. We found in related work that 77% of studies compare with not the personal baseline. And we feel this is a problem because these studies may be making conclusions that machine learning algorithms are working when they're not doing any better than guessing individuals are always a constant state. And I would like to point out that this is the case for all longitudinal data. So this is going to be similar if we're trying to track blood glucose level over time, blood pressure over time, anything where you're tracking individuals over time. So now I would like to make 3 suggestions that might avoid a similar situation of making conclusions that your machine learning is working when it might not be. First of all, we think it might be interesting to try to identify when methods will work on some individuals and not. We see a big spread, as we recall in the previous plot, that sometimes we can predict individuals' mood, or some individuals are very constant and others aren't. So we should look into whether this is, some individuals are easier to predict their mood, and some individuals can't be tracked with this method. Second of all, these data sets are highly sensitive, and we respect that. And perhaps sharing them is not the right way to go, but we could think about software sharing. So you can make a public database that would incentivize junior researchers to reproduce studies on their data set that they've collected that may be similar to another data set. And if you make a public structure that would incentivize this, maybe more people would do it, and we could compare between studies. Finally, we would like to emphasize community focus, not only on problem formulation, but problem evaluation. We think this is one example. We're sure there are other examples of where we need to think about in these new paradigms where we can collect vast amounts of data that we haven't before been able to collect. Maybe we need to evaluate them differently than we have been evaluating similar data sets previously. So to recap, I talked about 2 things. I talked about an example where maybe we're not evaluating methods sufficiently, and I talked about 3 suggestions that I'd like to make for concrete improvement. And now I'd like to tease you and ask for questions, but please come see me later. Thank you.
Our next presenter is Barbara Bulc. She is the founder and president of Global Development, and we'll talk about data science and a cross-sector collaboration to develop a global health mapping tool. Barbara?
Thank you, Susan. I'm very excited to be here today, especially because we are here during the UN Global Goals Week. And as you know, health, SDG 3, is one of the center. It's really, for me, it's the center of the SDGs, because unless we are healthy, there is no healthy planet, there is no healthy economies. We just cannot function. And my obsession is very simple. Can we use data to humanize our collaborations? I think I've been thinking about it since my consultancy is actually focused on building breakthrough collaboration between governments, nonprofits, businesses to provide affordable solutions like vaccines or other medicines or services to people globally. And why is it that this is so much on my mind? As you know, we are about 7.5 billion people today in the world, and sadly, around 85% do not have access today to affordable healthy nutrition, clean water, and so on and so forth. So why is that happening? Is it that we do not have the knowledge? Is it that we do not know the solution? No. In fact, it is. We have a lot of this knowledge. It is because we do not know how to collaborate. We have built the systems, including our educational system, that is built in the silos. We live in the disease silos. We live in sectoral silos. We live in the disciplinary silos. Data science is one silo among them. But I'm really curious, can we use, with all the knowledge that we have, to break through and humanize collaborations? We focus, as I mentioned, we focus on health. And just to give you some examples, why is this so shocking? Tuberculosis, you might know, it's still the #1 infectious disease. The bacillus was discovered well over 100 years ago. A simple solution. So what's wrong with us that we are not collaborating? So our idea was the following. Can we explore the use of data science and data collaboratives to be smart and think through how can we catalyze collaborations among institutions that we have built, as well as, of course, among people that are part of the institutions. I'm based in Geneva, Switzerland. So we took Geneva as an example. Why Geneva? Because Geneva, besides New York, is another center of global diplomacy. And I don't know how many of you know that this is also, Geneva is also the center of global health diplomacy. Not only that the World Health Organization is there and a few other big financing institutions like Gavi and Global Fund that are providing billions of dollars for solutions in vaccines, HIV/AIDS, TB, and malaria. But in fact, there are well over 80 organizations that are today key influencers in global health that are based in Geneva. They come from all sectors. And sadly enough, even though this is a very small city, it's around 300,000 people, you would think everybody would know each other, so this would be some little collaborative soup, right? Everything would be cooking there. Sadly, it's not. It's, again, the systems that we have built, the financing, the way it's flowing, the big egos, and so on and so forth. And even, I find it even more shocking because healthcare is, in fact, a caring profession. And we have forgotten that how important it is that we collaborate and care about each other and for each other. So what we did, we partnered with Columbia University, Malman School of Public Health, and we partnered with Kumu software platform. It's also a very creative startup out of Hawaii. So, and then we start mapping those over 80 organizations that are based in Geneva. By the way, they're all global organizations. They just have a footprint because, as you know, all the policy making is happening there. This collaborative tool was launched. It's on the website. You can check it out. We mapped it again as Sustainable Development Goals and against the targets in global health. And I'm not going to go through specific examples how you can find. The future is what is important. And that's why I'm here, because I'm very interested to continue building this model together with you, those of you that are interested in using data science and data collaboratives to catalyze collaboration. And we see these three opportunities where we want to expand. One is to build on the open data to really establish the open data framework. A lot has been talked today about it. So how can we bring that into global health? To standardize ontology for representation of this type of data and so on and so forth. Second thing, use of graph bases, databases. That's something that we need to explore further. And lastly, to speed up research, to use all these tools that are available. And then practically, what I'm interested is in working on specific use cases. But what we have heard, we have led extensive consultation with stakeholders, and we have identified specifically 2 areas. One is non-communicable diseases. Non-communicable diseases, this is cancer, obesity, 75% people will die globally of non-communicable diseases. So we have to speed up collaboration here. And the second user case is membership alliances. There are a number of global alliances. They have several hundred members, yet they are not collaborating. So I will leave it with that, and I look forward to speaking with you later. Thank you.
We have a fantastic next presentation as well. Nina Caesar is here. She's a researcher at the Institute for Health Metrics and Evaluation and is going to talk about demographics and social media data for health and whether or not it actually matters. Nina.
All right. Well, it's really exciting to be here and share this work in this really fascinating and diverse panel. This is part of a larger project in which my colleagues and I are sort of seeking to assess the comprehensiveness and representativeness of social media data for public health research. So as I'm sure many of you who came to this room can intuit, social media offer a lot of opportunity for studying public health. People have used websites like Facebook, like Twitter, like Yelp, to study things like vaccine sentiment, attitudes towards vaccines, that is, to study obesity, to study foodborne illness. And social media is also definitely of interest to this sort of nascent field of digital epidemiology, which seeks to use digital data sources to study the outbreak and spread of diseases. The big challenge in this, though, as you probably guessed already, is that the data that you're drawing from social media probably doesn't exactly match the data whose population you're trying to, whose health you're trying to study, right? So if we have a couple hypothetical distributions, we can imagine maybe our population age looks like that red distribution, but what we're pulling from social media looks more like that blue. So in an ideal world, we just adjust for demographic bias. But a lot of websites don't have that information, right? So what we need to do is develop ways to predict user demographics. And since we're doing this in public health, which often uses large, geographically dispersed, and even time-sensitive data, we want to do this in a way that's really scalable, but still high-performing. So in this paper, we focus on gender classification. And what we do here to ensure scalability and accuracy is use 3 simple classifiers that we combine in a weighted ensemble framework. The first method is pretty simple. You take users' first names, and I should specify that the name field is not the handle. The handle is one word that starts with an @ The name field is when Twitter asks you your name, right? So we take, on Twitter, people's names, and we match it to Social Security Administration data to guess what their gender might be. The second method is using word and character n-grams from user names in an SVM classifier to predict gender. The third is kind of similar to the first in that we're using first names, but we're kind of assuming, okay, if we can't directly match them, there might be sort of common linguistic structures, and we can use those as features to put in a decision tree to predict gender. And we can see in this graph on the right that method 1 is obviously really high performing. It does well, but it only covers about 67% of users because not everyone chooses to report their full name on Twitter. Methods 2 and 3 are fairly high performing, between 0.7 and 0.8 for all of the metrics considered. But we want to sort of combine these together and make something better. So to sort of sprint through our classification framework, what we're doing here is taking the public health data from Twitter that we're interested in, applying it through these 3 classification methods to get 3 vectors of predictions. And then we basically weight it using logistic regression classifiers, 2 of them, one for cases that are predicted by methods 1, 2, and 3, and another predicted by methods 2 and 3. To produce 2 vectors of sort of final classifications that we can combine and get predictions for every user in our data set that we can see do a pretty good job at inferring gender. So it's a weighted ensemble framework, uses 3 basic classifiers to sort of mash them together and create something better. So what we wanted to do was apply this gender classification framework to tweets reporting symptoms of foodborne illness, which is something that you'd kind of guess would not necessarily discriminate by gender, right? So we have geotagged tweets, about 36,000 geotagged tweets containing these symptoms of foodborne illness in the US. And just looking at the overall volume, you see sort of high intensity around the West Coast, a little bit around the Gulf and Florida, and some in the East Coast as well. And when we apply our gender classification framework to these tweets, we see some interesting patterns emerge. So if we look at this map, the dark green represents counties in which over 50% of the users tweeting are female. And you see a lot of dark green, right, looking at this map. If we zoom into California, which is one of the more active states in our data set, we see this sort of on a more micro level. About 8 out of the 10 most active counties in California are disproportionately female represented. So way more of the people tweeting, usually between 56 and 64% of the users tweeting are female. And this is very different than the sort of census gender population of California as well. So it's not just an artifact of the population itself. So what this tells us is that demographics do matter when we're pulling social media data to study public health, and people who are using this data to study health trends need to consider who's likely to be in your sample and how that affects the estimates that you're getting. And if you have questions, find me afterwards. Elaine, the principal investigator, is also here. We love talking data, so come find us.
Thank you very much, Nina. Okay, our next one is Ravi Rao. He's a professor at Farleigh Dickinson University in computer science, and he's going to share some insights about healthcare data that he got through using open source health data. Ravi.
Just use this, yeah. Okay, everything's on? Okay, thanks. Almost to the end of the day. So I get a chance to tie together many different ideas we have seen today. So first of all, my university is somewhere there, stone's throw. UN is a stone's throw in this direction. So I can tie some of these ideas together. I would like to acknowledge my student, Daniel Clark, sitting here. Will be at the poster session to follow after this. So this talk is about public healthcare data. First of all, I want to just change the perspective a little bit. I come from India. So I just did a search about the national motto. India, Satyameva Jayate. It's not a TV serial. Truth prevails. Okay? Truth prevails. Motto of US, in God we trust. I don't think I can sell this to my kids. I cannot tell them, trust God. Okay, what is it? What is the relevance to data science? This is what I see as the data paradox. The more talks I attend today, more confused I get. Because the more data sources, more technology, more stuff going on. It's like this real-time Twitter feed. I don't know how to read that. So we are moving away from the truth. So how do we solve this problem? Okay, I could continue. This could be a philosophy talk, but I'm in computer science, so I'm going to change. Trends in healthcare. Healthcare, just look, recent article a few months ago in Wall Street Journal. People want data. People want to know more. They want to know how much healthcare costs, how much my drug costs, how much does my treatment cost. Where are we now? So we talked about sustainable development goals. One of the goals is accountable government. Okay, after health, accountable government. So already there are places that are dumping tons of data. CMS is dumping tons of data. Let me ask the audience, how many of you have downloaded any public data file and looked at it? Okay, pretty good. How many of you have heard of University of West Virginia? That's much better than I expected. Okay. But I don't know if you know the context in which I'm going to ask you that question. Come later. Okay. So now that we have all this data, what are the opportunities? Okay, we can better understand the services provided. Where's the money being spent? Where are the inefficiencies? Maybe we can fix the system. We can benchmark service providers. We can also have the ability to examine disease trends. That's what I'm interested in. And the challenges are, of course, you have all worked in data science. You know, there's a lot of noise in data, no standardization. There's no standard analytics pipeline. Even though there's so many open source tools available, I cannot just say, OK, here's a data source from so-and-so. Just plug it in and let me look at some outliers. No, I can't do that. Okay. So the research goal that we have is to empower consumers. So we want everybody to be able to go download data for themselves and check, fact check. Fact checking is very important. And so many other requirements, like we want to scale to large data sets, perform the computations on a single platform. So we've developed this open source pipeline to start looking at data from different sources, cleansing it, and so on. So we've made some of the data available as well. It's all available for free. Results. You can come to the poster for details. Some of the interesting results. First of all, if you have noticed in about 2013, California introduced legislation, or I should say the CalPERS system, California pension system, said we will only pay retirees $30K for hip replacement. So why $30K? Okay, so I looked at data from New York State. You look at the distribution. Free data. 168,000 patients, that's pretty large. I just plotted the histogram and I say, okay, 88% of these had costs less than 30,000. So to me, that seems like a reasonable cap. Okay? So at least it provides a basis for understanding some of the government decisions. Looking at mental health data. It's another thing I've looked at in New York State for vulnerable population, age 0 to 17. What's the growth of different diseases? Actually, mood disorders is one after birth. Birth is the first expenditure, which is off the charts. But the next one is mood disorders, cardiac anomalies, and mood disorders. Look at mood disorders. Here's a trend. In the last 5 years, mood disorders have shot up 40% in many of the counties in New York State. Not only the number of cases, but the cost has also gone up 40% in 5 years. So if you look at other articles that came out in 2017, you say, oh, yes, this is a problem. But you can see it's in the data going back to 2012. So you don't have to wait for the news to discover this kind of phenomena. You can look for it and find it for yourself. Okay? So our framework enables you to find this kind of information. So it's of benefit to everybody. Okay? Now back to my question that I asked you. Who knows this person from University of West Virginia? Okay, even I didn't know. Arvind Thiruvengadam. I found out just because of this conference. I wanted to know because I was following this story. The biggest auto scandal in US history, $15 billion to Volkswagen. This is the man who found this. How did he do that? He stuck some sensors into tailpipes of Volkswagen cars. And he said, what's the emissions? It's 40 times what Volkswagen claims it is. What's going on? So look at this paper, and which has only 39 citations. Okay, see what impact this work has had, and nobody wants to cite this work. So think for yourself. All right. Conclusion. So there's a lot about data. I think a lot of interesting data, but the whole point is we have to be fact finders ourselves, and we have to verify what's going on. We cannot take anything for granted anymore. All right. Thank you.
Our final speaker for the day, I'm delighted to invite Yuan Lai to join me up here. Yuan is a PhD candidate at NYU and is going to talk about the impact of a topic near and dear to many of us who are urban dwellers, which is urban street trees and their impact on air quality and health.
So as we know, there are in global cities, including NYC, there are increasing concerns on the air quality and the respiratory illnesses, specific asthma. Specifically, we're looking at considering this as an environmental justice issue, focusing on the low-income neighborhoods, immigrants, and ethnic minority groups, because they normally, due to the air pollution issues, poor indoor living condition, and also the lack of awareness or simple access to basic health care. And what we focus on in this research specifically is on we're trying to localize environmental health impact of all documented trees in New York City with more than 130 species. So starting with a data integration, since we consider this as a multidimensional issue, we really start collecting data from multiple agencies, including the tree species and the census, population census, local complaints, and the asthma rate by the health district and also the community district air survey, specifically on PM 2.5. Previously, all this data were collected by different agencies in silos, so there wasn't any conversation or integration between these data sets. What we do then is to try to contextualize the domain the data with our domain knowledge in plants taxonomy. Specifically, we're interested in pollen because a lot of previous literatures indicate the pollen season gonna trigger the higher rates of asthma on the local level. So what we do is trying to associate the allergic pollen by the severity of the allergen and the active season with the trees. And then we developed the index score measuring the potential pollen impact to vulnerable population on the neighborhood tabulation area. So here we can see this is a way to contextualize the original tree census data and to show how these trees have different impact during different seasons based on their pollen activity. And here's the result about, we think the potential tree pollen impact could explain a little bit about the spatial disparity between the local asthma rate and the local air quality, that we consider the asthma is not a single result of the air quality issue, but maybe the local trees and the local demographic characters or even residential density have an impact to the asthma rate. And we also run the regression models to see how trees can impact the local air quality and the asthma rate by the species. So overall, the more trees gonna overall improve the air quality in terms of the level of the PM 2.5. But the initial models show there's very little correlation between tree allergen and asthma. But when we group the trees by zip code level by the species, it shows a profounding effect that certain species will have a close correlation with the local asthma. And we are also currently in future trying to integrate more data. So where you show here is that to associate local 311 complaints on trees, such as overgrown trees, dead trees, or broken trees, with the trees, and to figure out really this complex issue on the local respiratory illness issue. And what I'm trying to point out that this is Bronx Community District 1, which is the one suffer from the top one child asthma rate in whole New York City. So it shows that pollen, but at the same time, this is the second worst air quality measures in the whole city. At the same time, it's also one of the worst in terms of the building maintenance defects. So this is where really we think about, it's not just the air quality, but we also need to look at the indoor building condition and the energy usage to really tackle this complex issue. So overall, I think local tree may have impact on air quality, and we really need to think about the species maybe. And thank you all.